Good morning and good afternoon. Welcome to the second of two webinars on optimizing infusion therapy outcomes through pharmacy and nursing collaboration. My name is Jackie Cole and I'm a medical science liaison for infusion therapies and technologies with Baxter Healthcare. The purpose of this webinar series is to share examples of how pharmacists and nurses can collaborate around the area of infusion therapy and to provide education on the Infusion Nurses Society, Infusion Nurses Society, infusion therapy standards of practice. Next slide, please. Before we get started, I'd like to go over a few items so that you know how to participate in today's webinar. You can see here a screenshot of the attendee interface, and you should see something like this on your computer. You'll have the opportunity to type questions into the Q&A window. To activate the Q&A window, you can click on the Q&A icon at the top of the webinar window. The Q&A window will open on the right side of your screen, and you may type your question in the field labeled Ask Your Question here. You can enter your questions at any time, and we'll save them to the end of the presentation to address. Next slide, please. At the conclusion of the webinar, you will see a QR code for a brief survey. Please take a few minutes to complete the survey as it will inform us on topics for future webinars. Next slide. I'm not going to read Barb and Scott's biography since we did this in the first webinar, and our speakers have a lot of great content to get to today. If you're interested in learning more about Barb and Scott's background and experience, I would direct you to the recording of the first webinar, which I'll place a link to in the chat shortly. And with that, I'll turn it over to Barb and Scott.
Okay, thank you. So we're going to get started with part two. Optimizing infusion therapy outcomes through pharmacy nursing collaboration with a focus on extravasation prevention and management. Our objectives are as seen here. We're going to talk about some infusate characteristics in extravasation, best practices for pharmacy nursing collaboration in extravasation prevention and management, and some evidence-based practices to specific extravasation-related cases. We're going to go through some document review, some definitions, prevention, rapid recognition, and order sets and treatments. Barb?
Okay, so this will be our outline that we use, and what we really want to do is give you some resources as well. We did that on the first webinar, giving resources to pharmacy nursing collaboration. In that first webinar, if you weren't able to join us, we ended the process with several resources that you could use in your facility for nursing, or excuse me, for medication safety. So again, Scott's the pharmacy piece on this, and I'm in the nursing piece on it. In that webinar, we introduced the audience to this document, which you may or may not be aware of. And I just wanted to highlight it again so that folks knew what it was. It really can be an effective bridge between nursing and pharmacy. So it is the infusion therapy standards of practice. And as Jackie mentioned, it is the sponsoring organization is Infusion Nurses Society, but it is not simply a nursing document. It really is multidisciplinary. In fact, this current edition that you see on the slide, the 9th edition, was the committee composed primarily nursing, but we had a pharmacist with us that participated in those standards that were very pharmacy related. Scott actually is now a member of our 10th edition, and we just started the work to revise this document again now because it's a 3-year review cycle. We actually have a provider on our current committee as well. So very multidisciplinary, because it doesn't just address nursing needs within these. It really is infusion therapy standards of practice. What do we do with the vascular access devices, the medications we're giving, the specific clinical settings? So it really addresses all clinical settings, all age ranges, and it is used globally. It is a global standard for infusion therapy. It is used throughout the world. It's translated into other languages. This committee that put the 9th edition was represented by 4 countries, as is our 10th edition committee is again global. And our peer review process is quite robust. We had 144 peer reviewers from 12 different countries on this particular document that you see. And we want even more. In fact, we want pharmacists to peer review our document. And so if you're interested in that, you can reach out to us, maybe through Jackie at Baxter, because we'd love to have your review of this document when we get it ready. So again, it's multidisciplinary. We have a 3-year review cycle. The 9th edition that you see here has over 2,000 references, and it is composed of 66 separate standards within main sections within infusion therapy. And we talked over several of those sections in our first webinar, and basically then took it into some cases where pharmacy and nursing could do effective collaboration. The one that we really want to focus on today, though, is infiltration and extravasation, really focusing on extravasation. And it is one of the standards. As you can see, it's number 44 in this document. It's a very involved standard. I actually had the honor to be able to be the author of that one in the 9th and in the 8th edition. And indeed the honor to be chair of the committee for this 9th edition, and now again for the 10th edition. So again, it's a great resource. We really want folks to understand just how global it is. As we did the first webinar, what I found was that at least a third of the standards within this document really speak very directly to pharmacy nursing collaboration. It's also mentioned in multiple others, but really a third of the document is very, very relevant to this collaboration that we'll be talking about. Another piece, and again, our audience, I assume, is primarily pharmacy, but perhaps not. But just to tell you the nursing perspective here, the INS standards really are a main reference used in online nursing policy procedure manuals. So, and I've talked to multiple editors as I've spoken across the country. As nursing maybe comes to pharmacy with a question, this will be the lens that they most likely will be looking through, because it really informs their the infusion therapy portions of their policy procedures. Another document that we wanted to bring forward to you that you can avail yourself of, and this was in the Journal of Infusion Nursing in the September-October edition, is the development of an evidence-based list of non-antineoplastic vesicants. This is an important document. The first edition of this came out in 2017. Lisa Gorski led that group, and she led the task force again. And I'll refer to this group that you see in front of you as the vesicant task force, so you know what I'm referring to. We did have, again, a pharmacist, as you can see on this list, Jenny Ong, who Jenny and Ruth Van Gerpen wrote an article also for Journal of Infusion Nursing in 2020. That's a very important review of extravasation recognition and management. So again, that's an incredible article, and I'll refer to it a few times throughout the talk. But in 2017, Lisa led the group, and they recognized the gap in chemotherapy and oncology services. Their vesicant list is pretty well defined. It's incredibly well defined, and their management of them are well defined. But the non-antineoplastic vesicants, that's an area that is so diverse and not as well defined. And so they, in 2017, worked to bring a list forward. And then in this edition, the 2024 update, we applied more rigor to that list. And I'll give you an example here shortly. But what this document is, and it's an extensive document with multiple tables, it's an updated list of non-antineoplastic vesicants and their infusate characteristics. We also have several resources for extravasation prevention. There is an evidence table on safe peripheral administration of vasopressors, which is an incredibly hot topic right now. There's also a companion literature review, so on midline utilization, which again gets quite a bit of focus as people are trying to reduce their CLABSI rates. So the Journal of Infusion Nursing, the September-October edition, is those 2 articles only. It composes the whole journal because they are extensive. So again, we wanted to give you that as a great resource. So the methodology that we use to establish and to revise this list, just quickly, you can see on the left, obviously case reports and case studies, because that's the bulk of the research in infiltration and extravasation. But there are some systematic reviews that have looked at multiple studies, narratives. We looked at the FAERS report, Tristel's lexicon, Micromedics, and of course, drug information from the companies that make the medications. We looked specifically for drugs that were excluded from the 2017 list to make sure that what's new, what is known now, and there was adjustment in that area. Also looked at the vesicant list in 2017. Are they still there? Is there additional information maybe to increase the risk level? And then also, again, looked at product information, because many times that's the only place that an extravasation risk is noted. There's been nothing published on the drug. So our summary of risk stratification is on the right. I'm not going to read this table, but again, I really encourage you to look at this document. We designated, and these are new criteria, we designated it as a high-risk vesicant if there was truly 2 or more published case review or case studies, at least, of that drug specifically causing an extravasation injury with permanent functional impairment. And that's important. And I stress that because it's important that we publish when possible if you have a case. I know that's not always possible, but if you can get it into published literature, it is so valuable. The moderate risk is where there's a clear mechanism of injury. There's maybe 1 case of permanent functional impairment, or just a fairly good number of case reviews. The challenging piece of this literature, and really of extravasation in general, is that you don't always know what line that vesicant went into. And I worked critical care for many years. When the fur is flying, sometimes that detail in the documentation doesn't get there. And if you're doing a retrospective review, it's hard to see what went into that particular IV that now has necrosis. And it might have been multiple drugs, so which one caused it? And so again, that's some of the difficulty. So those often came into the moderate risk. And then cautionary risk are those drugs that very likely are have some vesicant property, but there's just not clear evidence yet. And so again, they're on a watch list, and those will be drugs that get a fresh look when we review and revise this list again in the future. So again, very important. We wanted to show that we really did a thorough job. And so this is just a quick table to show our main categories in that document are antimicrobials, electrolytes, nutrition because of high osmolarity, cardiovascular, sedatives, anti-epileptics, and then the other category. And then again, our cautionary drugs. And so there's extensive tables. I've just given you a quick look here. On the antimicrobials, remdesivir is a moderate. It has moderate evidence of vesicant properties. Vancomycin is still moderate. And there was a great deal of discussion at multiple different times in our committee. And it's mostly because it's difficult to say, did the vancomycin cause this injury, or was it the combination of drugs that were going into this patient? And so again, is it probably in the high risk category? It's possible, but we just didn't have the evidence to meet our criteria to bump it up into high risk. Calcium, no question, and I'll show you a great case study here shortly. Dextrose greater than or equal to 10%. And again, look at these and evaluate them against your extravasation lists in your facilities. That again has a high risk category. Lipids, moderate risk, and we'll talk about the mechanism of injury. Lipids just sit in the tissue if they get out there and cause inflammation, and they have nowhere to go. And so that really has created some interesting cases. So fat emulsions, cardiovascular amiodarone, just a nasty vesicant, also with irritant properties. Again, nursing needs to have a very healthy respect for what amiodarone can do in peripheral vessels. And most vasopressors, goes without saying, dobutamine is probably on the weaker side for vesicant nature, but all of them are very potent. And then propofol, again, very high. There's quite a bit of evidence on the vesicant nature of propofol because of its lipid base. Phenobarbital, moderate. And then you can see contrast media, very high. That's probably the best documented vesicant that we have. Immunoglobulin may not be on your radar, but it is moderate. Mannitol has been long considered a vesicant because of its osmolarity greater than or equal to 20%. And then you can see, I'm not going to read off all the cautionary drugs, but you can see the ones that are really examples of what's on the watch list. Also wanted to give you another example of a resource. This is the Nevis Toolkit, and it comes from the United Kingdom. And it is actually available if you plug in, and that's all you'd need to do is the Nevis Toolkit on extravasation, and you could get to this whole document. It is helpful. The interesting thing that I wanted to highlight from it, so NHS in the UK stands for National Health Service, and they call in this document, this toolkit, for every NHS organization to have an extravasation lead at their facility, who they say should be a specialist nurse or doctor. I'm sure partnered with pharmacy, because I can't imagine pharmacy not right in the mix. And that person needs to have a thorough knowledge of extravasation, really lead process change in the organization, so that guidelines are created and adhered to, staff are educated and are competent, and that we're monitoring outcomes. And so again, it's a great tool. And so really avail yourself of some of these. We wanted to just clarify on definitions. And I say this because definitions are not clear in the literature, and that's part of the issue. So I've got some ugly cases on the right and the left, and I'll go into those, but I wanted to define extravasation. It's the inadvertent infiltration, meaning the process, meaning it seeps out into the tissues from the vascular space of a vesicant solution. So knowing that it's a vesicant is critical from stem to stern for the whole lifespan of the administration. And that gets into the surrounding tissue, and it has the propensity to cause damage. An infiltration is the same process, but of a non-vesicant solution into those surrounding tissues. Why is that important? Well, number one, we want to call it an extravasation if it is. But again, in the literature, it's a little bit confusing. I'll call out the catheter dislodgement. That is a huge source of infiltration and extravasation when the catheter is not in the right spot. And peripherals, this is a much bigger risk. They can, if they're not well secured, the patient's moving, they can slip in and out of the vein or completely out of the vein and cause an extravasation. Happens to central lines as well, and we'll talk about that. On the left is a case of a 47-year-old woman that had spinal surgery. She went to the ICU, was intubated, thankfully a short intubation for her. She had a crystalloid fluid going in her left arm, and apparently it became quite edematous. They didn't understand the depth of that injury until they extubated her and found out that she was having extreme pain in that arm and actually areas of diminished sensory perception. And actually what was going on was compartment syndrome from that crystalloid fluid, and it had been missed by nursing. The article calls it an extravasation because of the extent of the injury, but it's not. It was a crystalloid fluid. It actually is an infiltration with compartment syndrome. She could have lost her arm if they had not extubated her and then really assessed and got good intervention. What you see is the evidence of the fasciotomy that had to be done to restore circulation to her arm. So again, that's an infiltration with compartment syndrome. On the right is a horrendous extravasation, a worst case scenario, no doubt. It is calcium gluconate. And this person came to this facility. It's a published case. And they got 2 doses of calcium gluconate. It was 1 gram in 50 mLs, given IV push into the same peripheral site in this forearm, an hour apart. Unfortunately, the site was a little ecchymotic during administration. They don't necessarily mention that the site was removed, but there was abnormality noted during administration. 2 days after this dose, the site began to get red and edematous and a little warm. By day 4, this person had severe pain in the arm. The hand began to be mottled. And by that point, there obviously was no saving the hand. It became necrotic, and she had to have a mid-forearm amputation. Definitely worst case scenario. But again, it really shows several things. One, that calcium is a horrendous vesicant, and it really, we need to be very careful giving it peripherally. Also, the delayed onset of extravasation. Whoever was taking care of her on day 4 may not have known at all that there was a peripheral IV site that caused it. Also, that the site needs to be normal when I'm giving a vesicant, and I'll feed on that a little bit later. And I'll hand it over to Scott for mechanisms of injury.
Okay, so the mechanism of injury for what Barb was talking about above, non-physiologic pH. So physiologic pH is 7.35 to 7.4. So essentially it's well accepted that anything less than 5 or greater than 9 can cause damage. pH extremes either way can decrease peripheral vein tolerance. It damages the cell proteins and eventually cause cell death, and then leading to endothelial damage, and then potentially vessels is susceptible to rupture. High pH may be more of a sustained effect. Osmolarity, non-physiologic osmolarity, anything less than 112 or greater than 900, remembering that physiologic osmolarity is around 282. And as we know, where salt goes, water follows, or in this case, an osmotic gradient. It can disrupt cellular ion transport, precipitate fluid shifts, causing cellular membrane dysfunction, leading to edema, necrosis, potentially compartment syndrome, as shown above, and cause precipitation into the soft tissues. Cytotoxicity, this is broken up into two things, DNA binding and non-DNA binding. DNA binding is those agents that bind to tissue nucleic acids, which then by definition or by proxy remain in the tissue, causing a prolonged course of damage and can be more destructive. Non-DNA binding can cause immediate damage, but they're easily metabolized and can be removed from the area quicker, so can cause less damage. Vasoconstriction. These are any of the agents that can lead to ischemia, and by the very mechanism of action, how they work, constricting those smooth muscles on the vasculature, on the capillaries, causing that ischemia. And then lastly, absorption refractory, which Barb had referred to earlier, and this is really around the lipids. Essentially, you have an insoluble agent that cannot be removed into by the vasculature and into the bloodstream and into the tissue, so they remain there and can cause extended periods of damage. And again, think of your lipids or propofol, which is lipid based. Next slide. Okay, so examples of the above, non-physiologic pH. Here's both ends of the range. Again, cyclovir, pH of 11, that can etch glass. Doxycycline, 1.8 to 3.3. Some other common ones, there's a lot to mention. We didn't have them listed, but you got vancomycin, common, 2.5 to 4. Gentamicin, which is 2.5 to 3. Promethazine, 4 to 5.5 rather. And remember on this one, even though that pH is a little bit higher, but there was that move with ISMP to remove promethazine IV from formularies. This is a common thing for antiemetic, but if you know it's a vesicant or known damage, use PO or PR. And this was the big thing with institutions, remove that particular form off the formulary. Acyclovir, 11, phenytoin, 12. And think of these agents that are commonly given. And this is one, phenytoin, where it doesn't come premix, right? The nurse has got to do that at bedside. Osmolarity, non-physiologic osmolarity, B50, 2500, mannitol, 1100. These are immediate use situations with hypoglycemia and stroke, respectively. Cytotoxicity, talking about the non-DNA binding and DNA binding, cyclophosphamide and vanco. Some other ones, non-DNA binding would be your vinca alkaloids and taxanes. DNA binding would be anthracyclines and alkylating agents. And the vasoconstriction, your pressors, norepinephrine, phenylephrine. And again, the absorption refractory, anything that has a fat emulsion.
And the picture based on the side, this is a gentleman that had a norepinephrine infusion in his cephalic vein there on the right hand. And the site looked normal up into the point where he started developing some leaking around there. And even after the IV was removed, it became this ecchymotic and actually ischemic area around the right wrist. And you think of all the structures in that area, not a good place to be administering a pressor because of the risk of damage to other structures in that area.
Okay, so we're going to go over some vesicant resources, high-risk patients, VAD selection, patency, and monitoring. So how does the clinician know they're administering a vesicant? One of the ways, and a very effective way, is to do a vesicant flag in the EMR. By doing that in the EMR, you can display that vesicant flag on the MAR and or an IV medication label. And this polarizes that end user via the MAR or that IV label and makes one think of the policy or refer to the policy. Then with the policy, you have the policy examples would be your high alert medication, your hazardous electrolyte, which can be the osmolarity or pH, and or an extravasation policy. You want to have that person use this to think of those policies, to go to those policies, and these policies should illustrate potential vesicants, as Barb talked about, let alone non-vesicants, medication extravasation category and or treatment if needed, and list the resources if there's any further questions. And this dovetails nicely with INS's recommendation that basically each institution should list what's a vesicant and an irritant based on the formulary agents they have. And then the resources these things are based on, and including the manufacturer's package insert or the commercial resources like primary references like LexiDrug or Micromedics, but also including that literature, those cancer centers or those multi-site institution or multi-center institutions. Next slide.
Yeah, just a little bit on the right side of this screen. So again, just an example of a MAR that has caution vesicant on it, so that whoever the clinician is that's giving this drug knows right up front, yes, this is a vesicant, and that's important in where do I give this and give it safely? Is it patent? And how often do I need to monitor it, which I'll address here shortly. And then just a snippet of a guide that I liked. It has color-coded and shape symbols on treatment, and there's 5 drugs that happen to be listed here that are all vesicants. Some have some phlebitic nature as well, and how they're treated: hyaluronidase, phentolamine, cold or warm. Those are types of tools that can be created by a facility and then given to staff so that they have that immediately at their disposal. So an important part of...
I'm sorry, Barb, I apologize. I had one more thought on that. I apologize to interject.
No.
At our institution or institutions, having this, we're going to get into this theme. Sometimes when we're giving these and these vesicant flags, we think about it in our policy, but the end users, the nurses and the end users at bedside utilizing this is how they identify, saying, hey, we have this is actually an identified vesicant, or we had an issue, and it may not be included. So as the theme of this entire talk, that constant collaboration back with nursing and pharmacy, where we may actual practice may notice that we're not flagging this, and we get that flag, and that has happened a few times.
Yeah, that is so helpful. So an important thing to notice or to include into extravasation prevention is just who are the high-risk populations. And prevention is key. You can't prevent extravasation, no doubt, all of them anyway, but we need to, as much as possible, prevent it and then mitigate any risks to the patient, limit the damage that can be done. So high-risk populations, no question, neonates and elderly, and I've given 2 examples of those. But one I really wanted to stress is altered level of consciousness. In the literature, as you see it, and read through these cases, altered level of consciousness, the patient's inability to say, this hurts, or I don't like the way that my arm or whatever feels, maybe the port site. That's a critical piece of assessment that we lose when the patient cannot communicate well to us with the infant or with the cognitively impaired or the sedated patient. Again, peripheral administration, very high risk. Because of all of the natures, we have to take special precautions on peripheral administration. Altered circulation in the area increases the risk of damage. And then the the more distal the insertion, obviously the less the circulation is in that area and the higher risk of severe damage. Again, the clinician needs to know the vesicant status. I've done a great deal of work in this in the large system that I work in. I actually had a pharmacist ask me, why does the nurse need to know up front that it's a vesicant? Don't they just need to know on how to treat it if there's an extravasation? And again, there's so much proactive work we can do. So an important point that I teach and that needs to be spread, whether the nurse is asking pharmacy or their nursing expert, is that the site should be normal. If it's a central line, it's a peripheral line, the site should be normal as I'm starting a vesicant. It really should have good blood return. There should be no abnormalities at all. Again, that calcium site was not normal when they gave it. And I don't know that the nurse knew that it was a vesicant when they were giving it. That's a red flag right there. Then, since it's normal as I'm starting, any abnormality occurring during or immediately after the extravasation should be considered an extravasation. Unfortunately, what we do in the documentation, because we have drop downs that say red, leaking, warm, painful, the nurse will choose those to describe it, but not call it an extravasation. And why is that important? It's because much of the literature here, if there's an actual study looking at outcomes, is retrospective. Retrospective studies in peripheral IV outcomes especially are incredibly limited, because I have to tell you, our documentation is not pristine in these areas. There are multiple gaps. And so to say that our extravasation rate is low on a retrospective study is in most cases inaccurate. So again, I want to put that out there as a strong statement. So I've got a couple of high risk areas. I've got the pressure bag in the left lower hand corner. When we give additional pressure on a peripheral IV site especially, we can back the catheter out of the site. We can cause fluid to leak out into the tissue. Same thing with the antecubital site, then with a blood pressure cuff on top. Unfortunately, I may not have a choice here if I've got a restricted extremity, but I really need to move that blood pressure cuff maybe down to a thigh to not put pressure on that IV site. The case of the foot, this is a young child that took several pills out of his mom's purse and ingested. I don't know what those pills were, but they had to give him a bicarb drip in the ED, started a left foot IV, and then wrapped it with an elastic rolled bandage, and then left it wrapped for hours. And you can see the damage to that foot because it had extravasated. It was high osmolarity. And this is a case that went to litigation because of a lack of documentation and oversight. The arm is amiodarone. And again, it created compartment syndrome. So not only extravasated, but then altered the circulation in that arm. They had to do a fasciotomy from that amiodarone extravasation. So again, we have to know the risk of the drug, the risk of the patient, what are their factors, and then is this the right vascular access device?
Okay, so this is a good example of some of those collaboration questions that come up. One of the common ones is with, say, norepinephrine peripherally or any of the vasopressors, how long can I run it? And if you look in the manufacturer's PI of any of these, they're generally going to state that manufacturers states that the short duration of less than 72 hours in a peripheral catheter, large bore proximal site. But the reality is move as soon as possible, right? Certainly coming in through the ED and we need to do life-saving measures and add pressors, that's going to take precedent. But we're going to want to move it as soon as possible. Do not wait. It's very common potential for extravasation of these agents and potential for the damage. And it can get overlooked. Follow-up or moving of the line. And Barb has taught me that's actually rotating the line, right, Barb?
Yes.
Yeah, rotating that line can get lost to other patient critical care needs. Can I run this PPN through a midline? I pause and I sigh as I'm learning more about this in the IV placement setting and administration. For example, a Clinomix E 4.25/5 has an osmolarity of 675 and a pH of 6. So this fits in our category of potential to cause damage, but for midline criteria, just is underneath it. It's got to be less than 900, and it's got to be pH less than 7, or around that. However, the chance or the of a extravasation in that line could be catastrophic. So an institution can make that decision with nursing and P&T to say, well, we're going to do this peripheral only or central line only, and keep it out of a midline, and that would be recommended. Compatibility questions. So phosphate is notoriously incompatible and can get into an immediate precipitate. So I've got a phosphate that I need to run, and there's a continuous infusion pressor or sedation. I can't pause it. What are the options? Well, what are the options? We got to run through this and take it one step at a time. Is it potentially one of those minimal things that phosphate is compatible? But again, we can get into some pH or osmolarity issues. If it's not compatible, does the current line have multiple ports? And is it a large board, that blood flow pulling that away? What's the status of getting a second line? Can we use PO or G tube, right? These are all interim steps in a fluid situation, and we've got to weigh each one of these things. And another good example of this would be, as Barb has already talked about, calcium gluconate and ceftriaxone. And it can be a calcium gluconate run, and or it could be from lactated ringers. This is a big precipitation thing. It has moved many lines or resulted in many lines getting replaced. Hypertonicity. Is it hypertonic saline or hypertonic questions? Is hypertonic saline compatible with PPN or anything along that lines? Or I don't know about other institutions, but providers want 3 amps of bicarb in a solution. Well, if we're going to do 3 amps of bicarb, we're talking sterile water, right? The more bicarb we're talking, that saline component goes to half to quarter to sterile water. So we've got to keep that isotonicity. We try to keep that osmolarity down as much as possible. Next slide.
So the INS standards do have quite a bit of guidance here. And again, this is what your nurses and your vascular access teams are speaking from. So the top line here is very important. There is a great deal of focus on CLABSI prevention, central line associated bloodstream infection, and that is critical. There is no doubt. But what happens sometimes is the focus is so on CLABSI that we avoid these other complications such as extravasation or thrombosis or phlebitis. And so our very strong statement in the INS standards is that the PIVC, including the midline, should not be used purely as a central as a CLABSI prevention strategy. Meaning, if they need a central line, they get it, and then they have exquisite care of whichever line is appropriate for them. Same thing with the implanted port. Our strong encouragement is to use that patient's implanted port. The person that has a port placed is often a very difficult IV access patient. And our foundation really should be on preserving their vessel health, not just CLABSI prevention, as important as that is, but looking at a holistic care of this patient and preventing all complications with the best vascular access. Our third bullet point there, this is our strong statement. It was in the 2021 standards, again on the 2024, and again in our vesicant task force. Do not use the midline catheter for continuous infusion of vesicant therapy, meaning pressors. It is not the right choice, and I'll explain why. Or do not use it for parenteral nutrition or other infusates of extremes of pH or osmolarity. It is not a PICC line. It can't be used as a central line surrogate because the distal tip in our country, and there's a lot of different versions of midlines out there, but the distal tip of the midline is right at the shoulder, which is a low flow vessel, maybe 100 mLs a minute, not high flow at all. And you're putting these caustic drugs in here, and norepinephrine is an irritant that can cause vessel damage, thrombosis, and possibly even extravasation. So again, there is an incredible lack of safety of the profile of the midline in continuous infusion of vesicants. There are some studies out there, typically retrospective or high risk of bias. We need strong evidence in this area. So our statement is based on the current level of evidence. There's also a risk of extensive tissue damage. If I'm working critical care and I have a sedated patient on the ventilator, and for whatever reason, norepinephrine was started in that midline, by day 2, I would bet a week's salary that there's not going to be blood return in that catheter because it's an irritant and because I've got a low flow patient. Plus, they're probably edematous. So if I have no blood flow, I've got a sedated patient, I'm giving a continuous infusion of a vesicant in that midline. How am I going to know that there is now an extravasation? I may not know until it becomes visible at the surface, and the risk of extensive damage deeper is huge. And I can tell you anecdotal stories from when I talk across the country. So the recommendation for time critical infusions, such as vasopressors, is to really think about how we need to do it. As Scott mentioned, you may have to do something. If I've got a midline and it's got a blood return and I need to give this drug, it's my only source, of course I'm going to use the midline, but I'm going to transition out of it as soon as possible into another source. And I would prefer the short peripheral, the superficial peripheral, because I can see if there's damage with it. I know what's going on there and I can monitor it much more easily. So again, those are a quick look at the guidelines that we have. Again, out of that vesicant task force, there are just some extravasation prevention tips. Peripherals, we need to really be careful on these patients. If I'm looking at their vasculature and it's very poor, they've had multiple venipunctures, they've had maybe vessel damage, small fragile veins, dark skin color increases risk, maybe a vasospastic type of condition like Raynaud's. If I have no blood return, and this is on the left-hand side of the screen, about 2/3 down, if I don't have blood return, I really need to come up with an alternative because blood return is very important. We do have some other ways to assess patency if need be, but again, that's very, very important. And in fact, if a case went to litigation and there wasn't a good assessment of patency as that vesicant started, that might be something that is taken into account as the case is explored. Again, altered or inability to communicate symptoms, sensory motor deficits, or inadequate length of the catheter in the vessel, and that can happen with peripherals. On central venous access devices, CVADs, again, I need blood return from every lumen, and I should have no exception. I hear nurses call pharmacy, can I give this? I don't have blood return in this PIC. The answer should be no. You need to get blood return back because you're flying blind, and the standard is clear, and I'll show you that standard statement. Retrograde flow from fibrin sheath can happen from central lines. Pinch-off syndrome can happen. And again, if the patient can't communicate, there's an issue. There have been some spectacular extravasations from central lines. So patency, you can see this is straight from the standards. It is a standard statement on 46.1. And when I say a standard statement, that means it is universal, it's accepted, and it doesn't even need references because this is truly accepted as the norm of practice. And I'll just read 46.1. Vascular access device patency is routinely assessed and defined as the ability to flush the catheter without resistance after establishing blood return from each lumen. And it's clear then also in the standards that that's required prior to vesicant administration. If the catheter doesn't have blood return, I might consider catheter salvage. That goes into a whole different line that we don't have time to deal with. But again, that's important. If I can't assure patency or can't return patency, then I really need to be thinking I've got to move this vesicant into another line. So occlusion can be caused by mechanical reasons. A kinked catheter can be caused by thrombosis, as you can see by the picture there, because usually a vessel injury, or from the chemical reaction, it might be maybe precipitate or lipid buildup around the catheter. So we need to work with pharmacy to say what's going on with this catheter. Can we salvage it in some way, or do we need to abort and move the drug to a different one? So site assessment as this drug is going on is very important. And at the top of my box there, I've got the word leaking. A lot of many of the research studies have leaking mentioned as a symptom of why the peripheral IV was taken out. They don't say it was an extravasation, they just say it was leaking. And so we're not capturing those in our data necessarily, but if it's leaking from the insertion site, the chance that some of that product is getting into the tissue is very real, and we need to pay attention to that. There are some extravasation detection accessories available on the market. Those are some things to think about, especially say for the patient in the OR maybe that isn't draped and we can't see the site. but the nurse is bound to this standard of care. Any peripheral IV, the minimum standard in an acute care facility is Q4 hours. And then with increased risk of the patient, the infusate, that goes up to every 1 to 2 hours. Again, we're held to the standard. If that's not clear in the documentation and it goes to litigation, that might be something that kind of shifts the case one way or the other if there was unclear documentation of the status while this drug was going. We have to palpate and inspect and ask the patient if they can tell us and make sure it truly is patent. So again, in the upper arm or the deeper peripheral IVs, very difficult to pick up until there's been more damage. CVADs must be assessed on a daily basis. And I've got some pictures of some troublesome lines. This peripheral one, it may be hard to see, but I've got the L-shaped here. So it's taped in a way that maybe their hands are on a walker or they're pushing out of the bed and now they've kinked the catheter and that's going to cause retrograde flow. I've got a PICC line here that's been definitely pulled out. I can't imagine a vascular access team keeping a line in. So this was nicely dressed after it really got significant tension on that line. And then the port, again, I've got a diagram that shows that the port needle is not fully based in there and the base of the port needle is not at the skin. And so it looks like that needle is probably moving in and out, causing an extravasation. So all of those things are very important. We'll look at a little bit as far as interventions and order sets and then have time for questions. And so again, we'll talk initial intervention, staging, order set development, and then finally monitoring the outcomes. So, and we'll share a little bit on this slide, but these are the steps as far as what to take in an extravasation, straight from the standards, most likely straight from nursing policy procedure. But obviously, if I suspect an extravasation, I'm going to stop the infusion and estimate the volume, because there are times when the antidote is related to how much probably got into the tissue. I don't want to flush the catheter. I don't know where the distal tip is. And so I don't want to insert more drug into it. I also don't typically want to give the antidote in that catheter because it might still be in the vein. And I don't want to just flush my antidote intravascularly. I want to give it most likely sub-Q. I want to put on an empty syringe, aspirate as much as I can, and then take the peripheral catheter or the non-coring port needle out. Consult pharmacy, get my treatment guideline. I don't want to put pressure on it, but I do want to mark the outside area, whatever's abnormal, so that I can assess and make sure that it's evolving in the right direction. And then try not to use that extremity to replace the vascular access device. Then really assess and treat the patient. And make sure that I'm assessing it according to facility policy. In our system, it's Q1 hour times 2 post extravasation, and then every 4 hours at least for 24. We don't mandate that in the INS standards, but again, that's a facility policy that staff would need to adhere to. Obviously, getting the provider to look at it, especially if there were signs of compromise to the circulation, and then make sure to know and to train staff that extravasation can occur, but the changes don't necessarily happen immediately. That site may get worse and worse, as we've shown you some examples. So I don't know, Scott, if you have anything to add on this slide.
Yeah, I mean, this is the area where it says consult pharmacy. It should be clear that pharmacy, there's a lot of steps that happen. Pharmacy doesn't have to be called, but can be called. And the thing is, can be called can be almost could be 100% of the time, or if the institution's done their job and the policy is clear, go through it. But when consulting pharmacy, we can help find said policy, interpreting said policy, help them find the treatment rationale for that particular one. Identifying that this medication is indeed on the list or is a vesicant as identified in the policy, type of extravasated med, the treatment, how to order it, order set questions, and the stat distribution of the med. All these things can be helped by talking with pharmacy. Again, if this is clear, you don't have to call pharmacy, but this is areas where we can collaborate.
And a tool that can help, and this is from the Ong and Van Gerpen article, and I'll just mention it quickly. We actually inserted this into our EHR. It is not a validated tool because it's difficult to do that with such a random complication, but it really helps the nurse to stratify how significant is this extravasation at the start, and then does it worsen. So stage 1s and 2s are very minor. I'm not going to read those, but stage 3s and 4s are quite significant. And the nice thing about this tool is it can be used for all ages because it's a percentage of area in that wherever the site is that's involved. And then you can see it has treatment options. So stage 1s and 2s definitely remove the cannula. Significant stage 2s that are bridging into stage 3 to 3s and 4s, consider and most likely consider an antidote, and then make sure and treat it per your order set, making sure the physician is aware, and then continue to monitor it and see, is there some kind of evolution? Again, if there's any abnormality to the circulation in that area or concern for the circulation, surgical consult should be mandated. And so again, this is a very helpful tool to stage. So again, we'll quickly go through these and show a little bit on order sets, and we need time for questions at the end.
Okay, so here's a good example of several things. Principally, the collaboration needed after a protocol's been developed or treatment guidelines. So vancomycin 1500 milligram has extravasated after the infusion complete. It's noted. The treatment is, this is right out of the package insert, and most treatment guidelines, hyaluronidase 15 units per ml, 1 ml, given as 5 injections around the site subcutaneously. Or if the IV catheter is in place, the same volume can go through the IV catheter. Nurse calls the pharmacist and states the catheter is in place, but the catheter volume is almost a mil. How would this be administered, since that would take that volume up? It is determined, pharmacist and nurse determine at bedside that volume is indeed 0.8 mLs. If the treatment's 1 ml, most of the treatment's not getting to the site. Looking into the manufacturer for vancomycin PI or lexicon primary reference or in general, doesn't state the logical, hey, what if we put the hyaluronidase in the catheter and flush with an equal amount of, saline? This is logical to put it into the site. It's not stated anywhere. So what should have been done? Do you do the IV catheter or do you do sub-Q? We know if we do it around sub-Q, we know it's in the site and it can do the treatment it's intended, and it's a guarantee that it's there. What if the catheter, as Barb has talked about, has gone out of the space, intravascular space, but what if it's now in the intravascular space? Potential is that medication could go IV and not to the damage of the area. So this really is a question, because this really becomes what literature is out there, what references, what efficacy has been shown with either. An institution could make a logical conclusion to do sub-Q only. They could state to do in the IV catheter. I'm not sure, but the point is, this is a great part for collaboration, looking for that literature and that evidence base. Next slide. And extravasation protocol, again, cannot stress enough that the collaboration for this is paramount. Another example of where things may not be as clear, vinca alkaloids. If this is extravasated, the treatment again is hyaluronidase, but in this particular case, the treatment states 1 to 6 mils of hyaluronidase for every ml of the extravasated drug. And that also this could be potentially repeated. Well, how do you operationalize this? For example, if a vinca alkaloid, it takes 6 mLs to make the bag, and the nurse would have to assess that something's extravasated, identify that this is a vesicant, identify how much of the bag has gone into the patient, and if, say, 50% of the bag went in, then per this policy, it would be 3 mLs of hyaluronidase to be ordered. And then that would have to be relayed to the provider so you get a correct order. And in a perfect world, as these steps are there, this is all taking time, and has been stated that this is an emergency. And what is the evidence, and reviewing the evidence of this variability. The couple studies that are on this actually refer to each other, but don't really get into the details. So again, not setting that it should be one way or another, but when it is noted that this could be done subcutaneously and it's a guarantee, you have to weigh the potential of this going through a catheter and the variability of the dosing, where other institutions, other cancer institutions may state the fixed dosing that has been prior to this of 1 ml and doing the 5 injections. So again, an opportunity to review that evidence, to have that collaboration in the institution to make up their own mind on that. And then lastly, the order sets. These things, if done properly, they give a clear antidote for the extravasated drug. They can be based on the antidotes and group the meds. That way it's clear, it's fast, it's pre-populated with the frequency and the admin instructions. The providers don't have to doing one-off orders where potentially they're searching for that particular antidote and they may not know it or look into the policy and then have to order it. These can be order sets. They foster communication about inherently through the nurse, the provider, and the pharmacist, because it's all pre-populated. It should be done with heavy collaboration with nursing and pharmacy and the provider. It expedites that treatment. The provider's not wasting time on the order. The nurse knows it should be pre-populated with admin instructions, and also can obtain or expedite communication about where to look. These pre-populated order sets will state whether this is going to be in the ADC, the automatic dispensing cabinet, or if it's coming from pharmacy. And then inherently, if they know it's not in their ADC, that if a facility has a tube station, that it can be tubed, or we need a runner to take it. And then lastly, that go live. After that go live, collaboration from nursing and pharmacy going over this and looking at those problems to clarify the order sets, to clarify the admin instructions, potentially drug distribution.
And again, I've got just a little bit of time here, but both Scott and I would be available if this is an area that you're working in. You can get a hold of us and we can help. We did a large system review here. We standardized a vesicant list throughout a huge list of facilities. We created those order sets as Scott's talking about. We inserted the staging decision-making tool into our EHR. We also included changes in our incident reporting system so that if the nurse said, I'm giving 12.5% of dextrose and it's an infiltration, our incident reporting system actually says, no, that's a vesicant, that's an extravasation. What stage did you give it? And by the way, you need to go back and document it correctly. So again, we closed the loop. And what that really has done for us as a system is created a dashboard to monitor our outcomes. So we now have the ability to say, what are the high risk areas for peripheral IV administration? How significant is antecubital IV placement? What ages? What departments? What is radiology seeing? Is it the IVs coming to them or the ones they're starting that are creating the issue? So that dashboard is really helping us to say where are our knowledge and our gaps, where can we do process improvement in our large system to really improve our patient outcomes. So that's exactly where we need to get to. So I'll do a quick summary. Again, prevention is key. We need to know the high-risk populations. We need to pick the correct vascular access device. We need to monitor correctly. We need to work with pharmacy to make sure that all of these things are in place. We encourage everyone. We've got the FAERS database there. Report, if you can, a case so that it gets on the radar. Very, very important so that we get to know extravasation better than we know now. So I don't think we have a great deal of time for questions, but again, we'll turn that over.
All right. Well, thank you, Barb and Scott. That was great information. Maybe, Barb, if you can advance to the next question so we can see, or next slide, so we can see the QR code. If everyone could please complete the survey during the Q&A, that will be helpful to inform us for future topics for webinars. So we have a couple of questions for you. Barb, you mentioned that the peripheral IV should be replaced with the central venous access device as early as possible for vasopressors. Was it intentional that a specific time frame was not presented in the standards of practice? And how would you define as early as possible?
Yes, it really depends on the patient. And actually, there is a vasopressor standard in the current edition of the INS standards, and I was able to write that. So basically, in the systematic reviews and meta-analyses, there is limited evidence to go beyond 24 hours, and that's what the standard says. That may change, I think, in our next edition because there's quite a bit of research going on in this area. But if you're rapidly escalating pressors, you're on a second pressor, and your patient's not doing well, or they're limited vascular access to start with, you really need to escalate to a central line. So there's so many variables that it really is a case-by-case basis. But what we don't want is a patient that's got 4 or 5 or 6 peripherals trying to avoid that central line and really doing damage to their vessels and maybe not delivering the IV therapy effectively. So again, it's a case-by-case basis, and peripheral administration of vasopressors can be done and can be done safely. Again, if you got more questions on that, I would be glad to talk with you.
Okay, great, thank you. Another question, does toe tect play a part in extravasation now?
I don't believe that is on our vesicant list. I don't believe it's hit the radar, but it may be that it just hasn't had enough published literature. Are you familiar, Scott?
I am not.
That would be something we'd need to research. I know that it's not on our list in the vesicant task force.
Okay, thank you. Another question, do the pressure monitors on some infusion pumps help with detecting infiltrations or extravasations?
Yeah, that is a fantastic question. And I'm assuming in the question they're saying, can the IV pump help me to recognize an extravasation because it's sensing PSI in the line? Basically, the companies would tell you no. You can't rely on that. It's a helpful tool in your assessment, but it will not be an extravasation recognition tool. There is nothing that can replace the actual assessment of the clinician, of the site, and blood return, et cetera. So again, it's a helpful tool. If it's alarming, you need to address it, but it may or may not mean that there is an extravasation happening.
All right, thank you. Well, I think that's the extent of the questions we have today. If anyone thinks of any questions after the webinar, you can email them directly to me. I have my email in the chat, and I will forward them on to Barb and to Scott. This concludes today's webinar. Thank you for joining us, and I hope that you found the content to be informative. As mentioned earlier, a recording of this webinar will be posted on our medical education website, and a recording of the first webinar is already there. Thank you and have a great day.